Good evening. Thank you. Thank you for joining me tonight on Facebook Live. I'm Dr. Iris Wang. I'm here to answer your general fertility questions. So do post your questions to us, and that way I can try and answer as many of your questions as I possibly can. Just a little bit of introduction first. I'm Dr. Iris Wang, and I practice in metropolitan Sydney and working in Chatswood, and I also have rooms in Burwood. You can find out information about me on my website, or alternatively on the IVF Australia website. And indeed, you can find a whole lot of information on the IVF Australia website, including information about other doctors, information maybe possibly answering your questions as well. And then there's always the 1-800 number where our 1-800 ladies can channel your questions to the appropriate department. Okay, so tonight we're talking about general fertility. Now we sometimes get into a lot of very specific things about, IVF, complex things about ICSI, genetic testing, and but there's still a lot of questions about, now where do I start? What should I be careful with when I want to try and have a baby? And when is there a problem? When should I seek help? What are the potential problems that may be affecting fertility? So I'm going to start doing that for now, just to have a little general chat whilst I'm waiting for your questions. So when you're trying to get pregnant, I think there are several areas to look at. Firstly is a lifestyle issue. And secondly, looking at more clinical specifics. And then thirdly, about timing of intercourse. And that's a question I get asked a lot as well. So in terms of lifestyle, I think it's important that we make sure diet, exercises, and weight, all these three things are very closely linked together. A healthy diet with lots of vegetables and proteins are important, and moderate exercises is not only good for your general health, but also for your fertility health and pregnancy health. So let's say just 20 to 30 minutes of walking per day for 3 to 4 times a week. Even that will be considered very good moderate exercises. And obviously weight is closely linked with diet and exercises. And when people are overweight, they sometimes feel disheartened that they can't seem to shake any weight. But just sometimes by 5 kilos of weight loss actually does a lot of good for your fertility as well. So I think don't lose heart, keep working at them. But on the other end of the spectrum, underweight, too thin is also bad for your fertility in terms of affecting your ovulation and your general health as well. And then when you come down to lifestyle issues such as drugs, for one, smoking is a big one. And obviously we advise strongly against smoking, and you don't want the chemicals from the cigarettes to be based in your eggs or sperm in those kind of fluid. And there's a lot of good evidence about the negative impact of smoking on fertility and on pregnancy as well. So it's time to stop, and at least time to start working towards stopping. Now, alcohol, there's actually no recognized safe value or safe amount of alcohol consumption for trying to get pregnant or for pregnancy. So we would say no alcohol is best. But in terms of general health, the recommendation is no more than 20 grams a day on any day. So there's no going out with your mates on Friday or Saturday and, you know, consuming 2 bottles of red. That's not acceptable. And I don't need to tell you about recreational drugs. It's definitely out. Again, you just think about all these chemicals in your follicular fluid, in your seminal fluid, and your sperms and eggs are, you know, soaking them. It cannot be healthy. You just need common sense to realize that. Okay, and then the clinical aspect is when you're trying to get pregnant. So this is more for the female partner now, is to go and visit the family doctor and get some infection testing done to look at rubella, German measles, or chickenpox, to make sure that you're already immune to it. Because if you got an infection in pregnancy, that could potentially affect the baby. So those are things to prepare for. And then comes the genetics. It is not recommended that you will consider genetic testing for autosomal recessive conditions. Now, by that, I mean a condition where I may have an abnormal gene, but otherwise a perfectly normal functioning gene, then I am perfectly normal. And same goes with my partner, an abnormal gene, but another totally functioning normal gene, and he's perfectly normal. So neither of us will be aware that we have certain conditions, certain diseases, you see. However, when we reproduce, we will give one of our genes to the baby. And with the 4 genes here, there's 25% chance we both end up giving the abnormal gene to our offspring, and the kid will have that condition. Generally, these are very debilitating and extremely serious condition. And some of the common ones we all know, most people know about would be, say, thalassemia, which is a severe anemia condition causing liver damage, spleen damage. And they are common in people from the Mediterranean area or Southeast Asia. And there's another condition called cystic fibrosis you may have heard of, which affects the mucus secretion of the body, affecting your gut, but more importantly, the lungs. So leading to recurrent lung infections. So the kid may be in and out of the hospital all the time, and maybe ultimately leading to chronic lung failure. So these are something to think about. Now, whilst we recommend these tests, a lot of these tests are still not Medicare rebatable. So thalassemia is Medicare rebatable, so we will usually do the test without even thinking about it. But some of the others are not. And for example, in IVF Australia, we can potentially screen for like over 500 of even up to very unusual autosomal recessive conditions. But there are certain ones which are more common, and it's certainly recommended that you will have these tests. And it will be good to talk to your family doctor about it and consider having these tests done. So that's the clinical aspect. Oh, then comes the part that people asked a lot about. I just think I haven't timed myself, right when I'm having sex. That's a very common question or common concern. Now, let me assume that the female partner has completely normal fertility. I'm sorry, not normal fertility, but normal cycle, which is, let's say, an ideal textbook-like 28-day cycle, okay? Generally, she will ovulate about somewhere in the middle, but not always day 14. And usually after ovulation, roughly 2 weeks later, you get a period. So this is what normally happens. And so not always day 14, could be day 12, could be day 11, could be day 13, one of those days. Okay. So it would be very tricky for you to say, I've got to time it exactly right at mid-cycle, because that's almost impossible. So if you can time sex between day 9 to 16, every second or third day during that period, then it's bound to be hitting the fertility window. And the most important thing out of that is the sperm's got to wait for the egg and not the other way around. Because once the egg is ovulated, it's dead 24 hours later. Where sperms can survive for about 3 or 4 days in the female genital tract, or even up to 7 days. So it's okay to have sex a few days before ovulation, but probably not a few days after, right? Well, not a few days after. So if you're trying to see whether you're doing it, timing it right, then this is the general principle to go by. And of course, there are all these apps and there are ovulation predictor kits around. Most of them are actually, the predictor kits are fairly accurate. But it's important not to get totally stressed. You know, the smiling face is up and I've got to have sex 2 days after the first smiling face appears, or, you know, that's because people can get a bit obsessed with that, and that's not necessary. But the difficulty arises when people have irregular cycles and say, 21-day cycles. So ovulation will happen quite early in the cycle. Say someone who has 5-week cycles, the ovulation happens much later. And therefore the potential fertility window widens and becomes much harder to time. I'm now alluding to when is there a problem. Okay, so in addition to ovulation, age is also a very important factor. So sometimes you can sort of see it's not very fair, is it? That, the usual life expectancy of women now is about 90, So how can you tell someone who is 40 that they're getting old? But eggs do not wait, because we're all born with the eggs we're ever going to have. And we just use them up in our lifetime. So obviously we end up using our better eggs when we're younger and our poor quality eggs when we're older, because cells undergo damages with age, and that happens with our eggs as well. So if a couple who have no other obvious reason and they've been trying for 12 months and the female partner's age is less than 35, we say you can try for about 12 months, and after that you really should go to the doctor and seek help and be investigated. If after 35, say 35 or more, then we will say 6 months before you go and see the doctor. The reason being, your fertility window after 35 becomes narrower than someone who's younger. So that's the reason. So age is obviously an important factor. And I've already talked a little bit about cycle regularity. So it means that, let's say, I've always had irregular cycles. So you shouldn't wait for 12 months or 6 months. You should just go and see the doctor and say, look, I'm trying to get pregnant, but I know I have a problem because my cycle is always irregular. And something should start, investigations or management should start early. Alternatively, I'm just giving you another example, and someone who said, look, I had pelvic surgery when I was 25, and there was a lot of endometriosis removed, and there was scarring. So under those circumstances, then of course, that you should probably go and see your doctor earlier, because potentially there are issues that can interfere with the egg and sperm getting together. Okay, that brings me onto this issue about investigation. So in terms of investigation, and you can, I'm kind of getting there, and you can see where I'm getting. We need eggs. We need a good egg. We need a good sperm. And we somehow need egg and sperm to get together. So we need the fallopian tube. And then when the embryo forms, we need a good home for that embryo to grow and become a baby. So we need the uterus. So when we investigate, we look at ovulation, we look at hormones, we look at sperm tests, we do special tests looking at tubes, uterus, to make sure all this is normal. And okay, so I've got a few questions now. So I'm going to start addressing them. And Jay asked that, can the ovulation kits be helpful for someone with PCOS and not always ovulating? Well, so this is a problem. Okay, so cycle irregularity is going to be an issue because, for example, if you use ovulation predictor kits, people with PCOS doesn't mean they don't ovulate, but they ovulate irregularly. So how do you know when you're going to use ovulation predictor kits? It becomes difficult. And when you're using the apps, when you're feeding the information of your cycle into the apps, if your cycle is quite irregular, then it mucks up the app's logarithm, you know, the kind of whatever it's meant to be. So they can't really work out your cycle either. So that is why I think you need to go and see your doctor. Now, however, if let's say someone with PCOS, you're still ovulating, let's say 8 or 9 times a year rather than 2 or 3 times, because PCOS is a condition of a big spectrum. Some people have more severe disease, some people have milder disease. So if you have regular-ish cycles, potentially you could still use the ovulation predictor kits. But I think the important thing is if you can't see if you're down for 2 or 3 months and you're not seeing anything, then definitely it's time to go and see the doctors. Okay. Do you think endometriosis affect egg quality? Yes, we do actually. We do think endometriosis can potentially affect egg quality, particularly in those with severe endometriosis, probably not so much with milder disease. Okay, and Eamon asks, are we born with poor egg quality? Well, I don't think so. I don't think we're born with poor egg quality. I think we are all born with fairly good eggs, generally. But, you know, there are cell damages, just like, you know, our heart undergoes age-related changes, and eggs are the same. And so we now kind of know oxidative damage is quite important to the ovary and to the eggs, and the eggs are very sensitive to them. And that is why there's a lot of, you know, supplements or whatever looking at hopefully improving oxidative damage by giving antioxidants and the likes. So potentially, you know, when you're younger, the eggs are better, but as time goes on, the eggs sitting there may be damaged as time goes on, and it become poorer quality eggs. So that's probably why as poorer quality eggs are associated with older age, the older age group. Now, I'm going to qualify myself. By saying older age group, I don't mean the person's actually older, but eggs are older. Okay, and I've got here some questions from people who's asked questions on Instagram earlier on. And someone asked about a simple question like workout, but it's a very valid question about what sort of exercise is safe while you're trying to conceive. So I think generally, if you're a kind of a person who generally works out, then you keep doing it. We usually recommend once you're pregnant, you might reduce the intensity of your workout to about roughly 80% of what you normally do. But you continue to exercise. And in fact, exercising is actually good for people's fertility and pregnancy health in general. But if, let's say I'm always a couch potato, I never exercise. And then suddenly, because I want to get pregnant now I feel, Iris Wang told me that exercise is going to be good. Suddenly I joined some sort of, boxing classes and that kind of thing. That is not the way to go. And you need to sort of ease into it. And so what I said before about just a little bit of walking, getting a bit of sweat out, 30 minutes a day, 3 or 4 times a week. So even that is a good general moderate exercises. But if you're kind of person who runs 4 or 5 Ks per day, then I think you should just keep going. I don't think it's going to affect you in any way. And not only is it going to be good for your physical health, it's good for your mental health as well. Okay, and now I also had this question from someone who is sharing her story that she has an AMH of 4 and has been trying to conceive for 11 months. And she's 28 years old. And her specialist has stated that she needs IVF. And she wanted to know what I think. The short answer is I agree with your specialist. Now, but at the same time, I want to reach out to you to say, at the age of 24, going back to egg quality again, AMH stands for anti-Müllerian hormone, and also a lot of people know it as the egg count test, right? So it's the count. It is produced by the small eggs on your ovary. And once your egg starts the cycle and gets into the cycle of ovulation, then the AMH production ceases in those little follicles. So it really is a reflection of the number of small follicles sitting there in your ovary, ready to do something. So it's your egg reserve. It's about numbers, but it's not about quality. And most of us doctors have all had patients who are young, under 30, but with a low AMH. And we tend to have this experience that although the AMH number is low, the egg quality is actually pretty good. So that at the end of the day, quality is what makes the pregnancy. So quality is the most important. So I don't think this is the end of the world. And in fact, I feel quite positive. But I think your window of fertility is narrow. So therefore, you should aim to try and get pregnant soon. And therefore, when your doctor tells you to go and do IVF, I would agree that you probably should go on to doing so. Okay, let's have another look and see what else been there. All right. Now, someone asked this question, that she experiences spotting for a few days before ovulation. Should she get this checked? This is a very common presentation, actually. So I'm glad you asked, because there will be a lot of people who are experiencing this like you. More than likely, this is completely physiological. And nobody understands why. And the theory is that, so the hormone rises, the estrogen and the pituitary type of hormone rises. And just before ovulation, there's a sharp rise, okay? And then a sharp fall. Sometimes with this sort of kind of a sharp up and down, it's like your uterine lining can't quite cope with it and then shed a little bit. So that's the sort of hypothesis. Some people have that hypothesis, but the real reason nobody really knows. So it can be physiological, so it can be. But the important thing is it's a diagnosis of exclusion. So you need to go to a doctor. And I think the things to check for is to check for infection and make sure your Pap test is up to date. Someone's had a look at the cervix. There's nothing growing on the cervix that may be causing the bleeding, and possibly consider doing an ultrasound to say there's not a polyp in the uterus, which may sort of cause abnormal bleeding towards mid-cycle, because things like a polyp can potentially affect implantation, not affect fertility, not affect your ability to get pregnant, but can potentially affect an implantation or increased miscarriage risks. Okay, all right. Okay, so going back to talking about fertility testing. So when we do fertility testing, you may or may not know that generally we will do a luteal phase hormone looking at progesterone production as a proof that the person has ovulated. Luteal phase is the second half of the cycle, is the stage that's, there's a medical name for after ovulation. But we also look at other hormones which can affect ovulation. For example, prolactin, which is a milk producing hormone from the pituitary gland, or thyroid gland, thyroid hormone level. And sometimes if we're concerned about PCOS, we may look at the male hormone level in the woman, the testosterone, the free androgen index. And of course, we make sure the antenatal blood tests have been done, like the rubella and the chickenpox immunity I talked about earlier. And then we obviously do a sperm count, which is a masturbation specimen. And then we evaluate the tubes. Now, there are several ways of looking at your tubes. So firstly, the old method, or the golden standard, it was a laparoscopy. And then an X-ray way of doing it is called Hysterosalpingogram, HSG. And nowadays, most of us do an ultrasound way of looking at the tube, which is called HICO-C, which stands for Hysterosalpingo Contrast Sonography. Bit of a mouthful, but we usually abbreviate HICO-C. So with an operation, the advantage is you can have a look at the outside of the uterus and the tube and look at pelvic scarring and the potential of dividing the scarring if you find any. But it does involve a full general anesthetics, and it's a belly, a needle through the belly button, a scope going through the belly button. And it does take the person about at least a week, usually up to 2 weeks, to recover, with a lot of discomfort and bloating afterwards. A hysterosalpingogram, the X-ray way, is basically putting some dye through the uterine cavity, and then the dye will go out, and you can take the picture showing the dye's gone out, and the cavity is normal, the tubes are normal, but you haven't seen the outside of the pelvis, or you haven't seen the uterus. So the HICO-C has the advantage of doing an ultrasound first. So you look at information about fibroids, and you look at information about the small follicles on the ovary, which is another way of looking at egg count, and they call it the antral follicle count. So that can correlate with the AMH level. And then they put some dye through the uterus to make sure the cavity is normal and there are no polyps or no fibroids sticking inside the uterine cavity, and they watch the dye go out of the tubes. So to know that the tubes are normal. And on the basis of all this, then we can make come together, have a plan as to where the investigation should go and what the next step should be. Sometimes you might, you might just need some of these tests to say if everything's normal and work out maybe you haven't been timing sex at the right time, and maybe try a few more cycles naturally before you come back to consider treatment. So there's all these different options, and that it will be variable depending on your circumstances and your investigation results. Okay, so I've got this question from Jay. Thank you for your question. So Jay asks if there has been a couple of unsuccessful implantations, can PGD testing be done on remaining embryos that are already frozen? Okay, that's a very good question, because that is a dilemma some people are under. Okay, so sometimes we have at times thawed out already frozen embryo, do PGD, refreeze, then get the information, and then rethaw and replace. And if you ask any of our doctors, we've had successful pregnancies that way. However, it is common sense that whenever you thaw an embryo out, then refreeze, rethaw, there is bound to be the potential for some damage for that embryo. So then the problem is that potentially good embryos gets damaged, and you end up wasting or losing a good, potentially good embryo that could have led you to a baby. So that's the dilemma we often have, and we usually would not recommend it. I think we're kind of half an hour now. I think I'm just going to answer one last question, because someone did ask me this to say about the number of successful IVF cycles and when should you look at other options. That again becomes very individualized, but I'll just tell you the clinical aspect of it. For most clinics, if you look at the pregnancy rate, there's something called a cumulative pregnancy rate that goes up like that, and then it flattens, which means with one cycle, we get maybe 35, 40% of people pregnant. Then there will be 65% left, and then another percentage will get pregnant with the next cycle, and then those people get out of the system, and then there's another percentage left, and then we try again, and then another percentage will get pregnant. And the way we look at the cycle is stimulated cycle. It is not including the frozen cycle, frozen embryo cycle. So the frozen embryo cycle we regard as a byproduct of the fresh cycle. So in most clinics, if you look at the clinical data, after 3 cycles, you kind of reach a plateau. Okay, so after that, there will be other people who get pregnant, but generally speaking, statistically speaking, the curve flattens. So if you want to look at it in a very clinical way, then I would say you do 3 cycles, and then you need to, and with the 3 cycles, obviously after each cycle, you need to look at what can be done differently and what can be done to improve the outcome. But if you say, what's the clinical evidence for any of this, then I would say 3 cycles, and then consider your other options. Okay. Right. So I think we've gone past our half an hour now, and I want to wrap up. And I want to thank you for joining us, and I want to thank you for all your questions. And I want to sincerely wish you all the very, very best in your fertility journey. Take care and look after yourself out there. Bye-bye.